Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm very pleased you could be with me for this next segment. Dr. Scott Smith, podiatrist. Dr. Smith, thanks so very much for being here.
Thank you.
I appreciate you coming on the program. Dr. Smith, I think that podiatry gets some attention, but I think there are a lot of misunderstandings about what you guys do. And really, I think we can summarize by saying you're the expert in the foot. Isn't that correct?
Yeah, I mean, certainly we get a lot of training on the foot. You know, we do 4 years of podiatry school and then basically do residency in foot and ankle, so we really spend most of the time with the foot.
And you guys are surgeons. You operate.
Correct. Yeah, board-certified surgeons of foot and ankle.
So let's talk about your average week.
Sure.
Some days you operate, some days I think you cover the wound care clinic, some days you're in the office doing evaluations, you can do hospital consultations. So tell me about your average week.
So that's kind of the nice thing about podiatry is it's very broad and it's diverse. So typically I'll be in the operating room for a half a day to a day, and then I'll do clinic, and in the clinic a lot of it's, you know, podiatry, sports medicine related stuff, and then I'll do 2 half days of wound care. So in that you're kind of getting a lot of different stuff within foot and ankle.
So we'll talk about the wound clinic.
Sure.
That you cover a little further on in the segment.
Okay.
But I just, by coincidence, I'm delighted to bring you on the program today. I had a patient come into my office who's interested in plastic surgery. Of course, we can't mention her. You did her bunionectomy, and she's delighted.
That's great.
So why don't we talk to the audience? Why don't we teach the audience about what a bunion is and how you manage bunions? For example, not everybody who gets a bunion needs an operation, correct?
Correct.
So let's talk about what a bunion is,
okay.
A very early change perhaps, and then let's talk about the indications for medical management and the indications or non-operative treatment, and then the indications for surgery. So
Sure.
What is a bunion?
So a bunion in essence is a dislocation of the big toe joint. So typically people will identify a bunion as like a protuberant area of a bone coming out the inside of their foot near their big toe. But what it is actually the big toe joint starts to dislocate and becomes deviated. You get the bump, which people will identify as the bunion, but actually what's going on underneath sometimes is that it's affecting the joint and it can lead to arthritis. So that's kind of a, you know, definition of a bunion.
So why is it that people get bunions? I mean, it seems to me that they're so common.
Right.
And even younger people can start to get a bunion. Is it because of shoe wear, high heels, or just it runs in the family, or because a person is a long-distance runner or not a long-distance runner? I mean, why do people get bunions?
Typically a couple of categories. So one would be, you know, it's hereditary. So someone in their family has a bunion, and what I found is that whatever the patient, whatever type of patient's in, whether it's guy or girl, will always blame it on the other, you know, like the parent. It's never their parent. It's always like, oh, it's my mom's, you know, it's like the other parent that always gets blamed. But somebody in the family will usually have a bunion. It also depends on the architecture of your foot. If you have a high arched foot or a flat foot, oftentimes those will, you'll have bunions in those types of foot types. And then the third is biomechanics. So there's a whole host of biomechanical things that you can have wrong overpronation, things like this that can actually increase the chance of having a bunion. Okay.
Well, Dr. Smith, can we sort of summarize for our audience what we mean by pronation?
Sure.
And there's inversion and eversion, and is there supination of the foot? I know certainly there is of the hand.
Right.
But can we explain to our viewing audience what we mean by those terms?
Yeah. So pronation is really when your foot turns out. So when somebody has a flat foot, or when you pronate, you evert your foot. That's kind of the same thing as pronation. And then supination would be more turning in, or a high-arched foot. Somebody that has a high-arched foot typically supinates more. And so those are two kind of broad categories to put you into a foot type. But yeah, they usually fall into those two categories.
Okay, well that reminds me of another question.
Sure.
I don't know if this is digressing or not, but some people use this term, and they say, I have flat feet, or flat feet run in the family, and so we need to get an arch support or orthotics.
Yeah.
Can we talk about those issues now? Is it true that some people just have flat feet and other people have high arches? Is that?
Absolutely. So you can have either a flexible flat foot or a flexible high arch foot. But to answer your question, yes, orthotics are an indication for those things. It's interesting you bring that up because there's over like 1,000 different orthotics on the market. And it even brings up another interesting thing about barefoot running. So this is a new thing too, where people are coming in and they don't even want to wear shoes anymore. So there's kind of two theories to this, but the one that has the most evidence in the literature is that, yes, you need an orthotic for certain types of foot problems, especially flat feet. That's definitely one that you want to have a orthotic in. And the thought is that it puts your foot into a neutral position and takes pressure off of the joints and aligns your foot, your ankle, and your knee.
So with an orthotic, that's sort of like an appliance or a shoe insert, right? Mm-hmm. You can affect, should we say, the posture of the foot or the architecture of the foot, and actually influence the health of the foot and ankle. That's
exactly what it is. So yeah, we'll take it's almost like a contact lens for your eye, but it's obviously of your foot. So we'll take a mold of your foot in a certain position, and the position that we try to capture is the one that puts the least amount of tension on the joints. So you'll put that in your shoe, and yes, it'll affect the architecture of your foot and take pressure off of the joints.
Okay. Dr. Smith, I appreciate that, and I feel like I've totally digressed. I totally took you off the subject. So let's go back to bunions, if that's okay.
No, yeah.
So you've defined what a bunion is, and that's essentially a dislocation, or can I say subluxation, at the base of the big toe, where the big toe sort of starts to drift off to the outer part of the foot, right? Okay, so let's say you see a person and it seems like they have a very early subluxation, very early bunion. Now, do you recommend surgery right away? How do you manage a person like that?
Right, so the first thing to do is to get an x-ray and actually measure the angle of the bunion, and then by doing that you can kind of categorize it into a mild, moderate, or severe bunion. So if somebody comes in and it sounds like they have a mild bunion or even a moderate bunion, no, you don't typically need to do surgery. You can do, so if you fall into two pathways. So one would be conservative treatment, the other would be surgical. So the conservative would be orthotics, like you were talking about, and that's about it. Changing the shoes that you wear, that can also be helpful. But all of the straps and devices that actually try to pull your toe back over, the bunion is actually dynamic, so as soon as you take off whatever type of strap that you get, the bunion will come right back.
Right. Now isn't there like a little pad that people can get at the drugstore or pharmacy that goes in between the great toe and the second toe to sort of help realign things?
Yeah, I mean you can, there's a whole host of different pads, but yeah, there's one that goes between the big toe and the second toe. There's also this thing called yoga toes, which is basically that for all of the toes. And they're okay while you have them on, but as soon as you take them out, you're kind of back to square one.
Okay, so why, if bunions are so common and even younger people can start to get them, why do we worry about them? Eventually, do they become a problem, or do they become painful? Like, why do we ever have to operate on a bunion?
Good question. So for two reasons. One would be pain, and the other would be arthritis, or joint pain. But typically it'll present as pain in a shoe, so someone will come in and they can't wear the shoes that they want. The other one is that they're actually getting joint pain. So, and it's interesting, reconstructively you want to actually try to align the joint before it becomes really bad. Like a lot of people will say, shouldn't I wait until I can't walk to have anything done with the bunion? And really no, because at that point you want to be able to spare the joint and do something that you can realign the joint versus put an implant or something like that in. So typically it'll be pain, bump pain or pain in the joint that people will present with painful bunion. And you can wear, the other option would just be to wear Birkenstocks. A lot of people, well, what can I do? I mean, you could literally, if you just wore Birkenstocks, you probably could live with a bunion, but a lot of times obviously people don't wear that and they can't fit their foot in the shoe.
Okay, so that leads me to my next. That's a perfect segue to some things on my mind. You barely can go on the internet or sometimes pick up a newspaper and hear about how high heels are bad for women's feet, but women continue to wear them.
Yeah.
So is it true that high heels can actually be bad for a foot and ankle, or is it just it might hurt if they wear high heels for a few hours?
High heels are pretty much bad for any forefoot condition. The only thing that they're good for is like an Achilles tendon. Not good for, but the only thing that they don't make worse would be like an Achilles problem. But because you've been talking about bunions or anything with the big toe joint, it really causes an increase in the symptoms, because when you wear a high-heeled shoe, it basically dorsiflexes or pulls up your big toe, and it'll jam that joint. So any kind of pre-existing bunion or anything like that will be made worse with a high-heeled shoe. And it's funny you say that, because even if you say that especially if women are wearing, you know, nice shoes, they don't care, it won't matter at all. You know what I mean? It's like, there's very few people that you're like, you should wear a, you know, New Balance, and they're like, thanks, I'm going to do that immediately. It's like, so, you know, people like to wear nice shoes, but I'd say anything with the big toe, it will increase some of the symptoms there.
Well, they like to look good,
They
right?
do,
I mean,
yeah.
people like to be fashionable and stylish.
Yeah, you never see like anybody on the red carpet with like a good pair of Brooks. You know what I mean? It's always like
the hot
a nice
shoe.
shoe. Exactly.
Right.
Yeah.
Okay. So before we get on to wound care, I
Yeah.
keep digressing.
Sure.
So back to bunions.
Okay.
So when a person finally gets to the point where they need an operation,
Yeah.
what things do you consider and what do you counsel them about?
There really are, if you look at bunion procedures, there's a lot of them. They come down to two different types of categories that most of them fall into. And one of them is the most common type of bunion procedure done, and it's called an Austin bunionectomy. And that's a weight-bearing procedure. So all of this has to do with how big that angle is. So typically, if we measure, it's called the intermetatarsal angle. And if it's bigger than 15 degrees, we tend to do a fancier procedure, which basically means you have to stay off your foot longer.
Yeah. Let me interrupt
Sure.
for just briefly. So
Yeah.
when you talk about the angle,
Yeah.
what you mean is how much the great toe, or the big toe, how much it deviates or turns toward the outer part of the foot.
Right.
That's what you mean by the deviation of, or the angle deviation.
Yeah, I mean, it's literally a bisection between the first metatarsal, the second metatarsal, and you measure that angle.
Oh, okay, so the metatarsal,
Yeah.
so our audience is clear. Those
Sure.
are the main longer bones in the foot.
Correct.
That's the metatarsal.
Yes.
And then the great toe is made up of phalanges.
Right.
And so that creates an angle, right?
Yes.
It can be straight, which is 0, or markedly deviated, right? And that leads
Exactly.
to a bunion.
Yes.
So you measure that angle.
Yeah.
Okay, and then what?
And then depending on how big it is, that will categorize you into really two different types of procedures. And one of them is this Austin bunionectomy, and the other is a closing base wedge, or a procedure that's done further down towards your heel. It's basically 85% will fall into a category where you can have a bunion procedure done and you can put weight on it after the surgery. So it's a weight-bearing procedure. You're in a boot, but you can walk on it. And then really, maybe 5–10% at most of the more severe bunions, you have to do another type of procedure where you're off your foot for up to a month, 4 to 6 weeks really. So that's kind of the thought process when you look at it. You also have to evaluate it clinically, and is there joint pain and other things like that. So.
Okay, so Dr. Smith, let's summarize what you mean by, say, an Austin procedure, Austin bunionectomy. Are you replacing that joint? Are you taking it out and putting in like a silastic replacement?
Right.
Are you just straightening it out by resecting it?
Right.
Are you fusing it? So just in summary, what do we mean by that?
So with the Austin bunionectomy, it's a joint-sparing procedure, so we're not using an implant. We're actually leaving the joint, which is nice for that procedure. And we're actually making a cut in the bone, or called an osteotomy, where it's in the shape of a triangle. And it's a very stable cut, and we're actually, if you can imagine, moving the bunion bump over, correcting or reducing that angle, and then holding it in place in that position. So that's really the Austin bunionectomy. But it's actually a bony procedure that tries to decrease that angle, that intermetatarsal angle, and align the joint.
Well, that's fascinating. And it's a fairly common procedure, fairly common operation in this country, isn't it?
It's very common. Yeah.
Okay, so I want to talk for a few minutes about another part of your week.
Sure.
You supervise and work in the wound care center.
Yes.
It seems like frequently people will have problematic wounds of the foot. Isn't that correct?
Yes.
So why is that? Why are there problematic wounds of the foot?
I would say that why there are problematic wounds in the foot, they typically fall into 3 categories, at least for what I do there. One would be venous stasis disease, or a blockage of the veins, allowing the blood to go from the foot back up to the heart. The other would be what's called peripheral vascular disease, which is the blood flow going to the foot, not getting there. So you have a lack of blood flow going to the foot. And then the third one would be diabetic neurotrophic ulcers, or ulcers from having diabetes. That's probably the most common 3 that we see there at the Wound Care Center.
Well, certainly we know, plastic surgeons know, that the blood supply, vascularity, is key for tissue healing, for wound healing, for the health of the tissues, health of the skin, etc. And of course, the foot is the most distant part of the body away from the heart, from the pumping organ, right?
Yeah.
So if there is any diminished blood flow to the foot, whether from hardening of the arteries or atherosclerosis or blood vessel disease or diabetes affecting the microvasculature, that can dramatically affect wound healing. Isn't that correct?
Absolutely, yeah.
So what is that like for you in wound care? You have physical therapists, you have wound care technicians and assistants working with you?
Yeah.
So you're the supervisor, manager, director?
Yeah, I mean, the nice thing about the Wound Care Center now is that there's a whole host of different specialties that work there. So like you're saying, physical therapists, medical assistants, podiatrists, and really important to what you're talking about are vascular surgeons, which we work very closely with.
And plastic surgeons.
And plastic surgeons too, absolutely, yeah. So there's plastic surgery, we have radiation oncologists, we have general surgeons, so we're kind of able to collaborate and put all our ideas together, and we can refer them to the appropriate people quickly. So that's the nice thing about working at the Wound Care Center.
So you see, basically, you don't see simple wounds much, but you see problematic, difficult to heal wounds.
Problematic, non-healing wounds with like a lot of different comorbidities. So yeah, they're complex.
Okay, Dr. Scott Smith,
yes.
Podiatrist.
Yes.
Now, we only have about a minute left.
Okay.
But I heard something about a new laser that you guys use and to get at something called onychomycosis. So I think we can define for our viewing audience what we mean by onychomycosis, and then very briefly tell us about the new laser treatment.
Sure, so onychomycosis, really nail fungus. We see it a lot, and really two ways that have shown any success. One would be a pill called Lamisil, the other is the laser. The pill is sometimes has liver toxicity, so you have to monitor your liver. Some people don't like to take it. Laser is about 75% successful. You can do 1 to 2 treatments, so usually 1, if it's very bad 2, but you don't have any of the side effects. And it's easy to do. You basically reduce the nails and get them as thin as you can, apply the laser, and then follow up and then do it again in about 3 to 6 months. And it has really good results.
So it's a laser treatment.
It's a laser treatment.
That will help to diminish or eliminate fungus from the toes, onychomycosis, the
Correct.
toenails.
Right.
Amazing. And
Yeah.
it works how often?
75–80% of the time with 1 treatment.
Amazing. Well, Dr. Scott Smith, podiatrist, if someone is interested in bunions or orthotics or the onychomycosis laser, what number do they call, or do you have a website? Or?
We do. So the telephone number is 831-649-3338. The website is Monterey Foot Doctor. That's Monterey and then foot and then doctor spelled out doctor.com. And we are actually moving our existing office right now, starting Monday of next week, to Monterey Spine and Joint on 12 Upper Ragsdale. So we'll be in a new facility too, so we're real excited about that.
Excellent. So one more time, podiatrist, you're a foot expert, Dr. Scott Smith, 831-649-3338, or the website is montereyfootdoctor.com, and those are spelled out words, montereyfootdoctor.com. Dr. Scott Smith, podiatrist, thanks so very much for coming on the program. I hope you come again.
Hey, anytime. I'll be here tomorrow if you want.
Once again, this is Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and we will be right back after a very brief pause for a very good cause.